Hello, and welcome to TherapyED's content review on the topic of autism. My name is Gina Keene, and I'm a speech-language pathologist at Children's Hospital Colorado. I serve on their autism team, as well as their AAC team, doing clinical work. I'm also on an interdisciplinary team there that does evaluations for autism. I've had a 20-plus year career of working primarily with autistic individuals, both pediatric and adult. So I hope that the information that you find on these slides will help you as you prepare to take your exams. I hope that it will help you solidify your knowledge and skills in the area of autism. I also would like to invite you to join me for the open office hours on this topic to review questions that you may find on the praxis and to go through some case studies and to bring any questions that you may have regarding this topic. Some business that we have to go through is that I want you to realize that this presentation is the property of TherapyED, and as such is protected by copyright for them. Therefore, there are no audio recordings or video recordings allowed of this presentation. We ask that you do not take pictures or screenshots of this presentation, or that we also ask that you do not store or transmit any portion of this information electronically or via other means such as Quizlet. This presentation will be available for you to go back and review as many times as you need as you are preparing for the praxis. Let's start with talking a little bit about autism and what it is and where our understanding of it came from. Historically, autism was first described by Leo Kanner in 1943. He found there were these behaviors that he was seeing in children, and he wanted to be able to describe that behavior, and he came up with the word autism. Over the years and through time, we have come to have an understanding that the etiology of autism is a neurological biochemical disorder. It has changed from our beginning understandings where we thought that it was a mental health disorder or perhaps a parenting disorder. There was a term that went around called refrigerator moms. It was thought that maybe these children were more into their own self-preferred activities, in part because their mothers were not reacting to them. Research over the years has shown that that is not true. We recognize that there are a variety of interactions that are taking place within individuals who are autistic, from genetics to environment to neurochemical and neural connections. We know that because of those interactions and because of the difficulties that are sometimes caused by those, that we will see differences in behavior. While this is a neurological biochemical disorder, the way that we see it is through behavior. The way that we describe it, the way that we recognize it, the way that we assess it is through behavior characteristics. And we see these behavior characteristics or these behavior differences in the areas of social reciprocity. There may be differences in speech and language development, differences in interaction with objects, how an individual interacts with objects, how they interact with individuals and those objects during two-way interactions and in play. We also may recognize that autistic individuals will have different sensory experiences within their environment. We recognize that there are differences in flexibility and a need for sameness at times. One important thing is that we recognize these differences early on. So we see them in early development, and they continue through the lifespan. Our understanding of the term and the diagnosis of autism has changed through the years. Our most current understanding and labeling of the diagnostic criteria for autism comes from the DSM-5. This is from the world of psychology, the Diagnostic and Statistical Manual. This is used, in the field of psychology to talk about different behaviors. And in this manual, and our latest understanding, comes the new criteria for autism. So what does an individual need to be doing in order to be diagnosed with autism? Well, they must demonstrate difficulties in social communication, difficulties or differences. And we're going to be talking a lot in this presentation about this idea of difference versus a delay. And we're really going to be talking a lot about the difference, this idea of a difference in quality. Because we are trying to describe behavior, it sometimes is not necessarily objectifiable. I mean, it's not easy to objectify, and it's not easy to necessarily characterize, except in this idea that this is different. The quality of this looks different. The quality of this interaction looks different. So we're going to be talking about those kinds of differences. So for a diagnosis of autism, there must be differences in social communication. And an individual, in their behaviors, again, we're looking at behavior. We're looking at how does somebody behave? How is this shown outwardly? They must demonstrate all three of these areas. They must have difficulty in social reciprocity. So social reciprocity is that back and forth. And it starts early in the being able to do some vocal play back and forth, to those early social games that babies play, peekaboo, being able to want to take those turns in those interactions, recognizing that you have a partner within those interactions. It's the basis for communication. It's the basis for conversation. It's the basis for relationship. It's the give and take between two individuals when it comes to communication. Also, you need to see deficits or difficulties in nonverbal communication. So these are things like eye contact or eye gaze or use of facial expression and the use of gesture, not just the use of them, but also the understanding of them. So for instance, one of our early signs that we look at is a child pointing by 18 months? That is a gesture. That is a means of communicating to somebody what they want. So if we're not seeing that nonverbal communication, or we're not seeing nonverbal communication mixed with verbal communication, those are differences in quality of that communication and the ability to use those methods to communicate what it is that you want to say. And the third one that an individual must demonstrate is a deficit in maintaining relationships. And this comes across in how an individual plays, how an individual initiates interactions with other individuals, how they respond to those same bids for interaction. Can they keep those interactions going? Do they have a mechanism to let somebody know, yes, I want to play. This is, I'm enjoying what we're playing. Can we keep playing? Even if there isn't words, can they keep those relationships? Do they have friendships? Are they interested in playing with other children? Are they interested in interacting with others? And when we see differences in those, then we have all three of those. That's the first area that helps us make a diagnosis of autism. All three of those must be present within behaviors. In addition to the difficulties in social communication, we will also see difficulties with restricted and repetitive behaviors. Sometimes you will hear these called RRBs. So there's two sets of criteria that an individual must meet. The social communication, they have to meet all three. And for restricted and repetitive behaviors, they have to demonstrate at least two of the following. They have to have stereotypical movements. So this could be anything from hand flapping to spinning to running back and forth in a room to playing only one way with a certain toy. Any sort of movement, maybe it's a tick on the face, something that is done over and over and over again. They must another area that they can demonstrate is an insistence on sameness. So always having to wear the same color, always having to eat the same foods, always wanting to sit in the same spot, always wanting the routine to change, and when it does change, it becomes really difficult and very upsetting. Another area that they could potentially demonstrate for the restricted and repetitive behaviors is having a highly restricted or fixated interests. So they may only want to talk about one cartoon character, or they may be very interested in trains. They may be very interested in some special topic, so much so they're so focused on it that they become very, very almost like an expert in that area. And lastly, the other area that they can show differences in for restricted and repetitive behaviors is having hyper or hypo sensitivity to sensory input. So this could be difficulty with loud noises, bright lights. It could be sensory seeking, to where you have a kid who is crashing into you, or who is maybe walking on their tiptoes, or always trying to not being really aware, not always being aware of where objects are in their environment. Maybe they're tripping and falling over things because they're unaware of that. So if they demonstrate that those 3 areas of social communication, and they demonstrate 2 of these areas of restricted and repetitive behaviors, that leads to a potential diagnosis of autism. Really quick, I want to put a little side note in here about this diagnosis of autism through the DSM-5. It is a medical diagnosis, and it is typically done by either a developmental pediatrician or by a psychologist who is trained in the area. And it is different from a child getting this diagnosis within a school. For a medical diagnosis, it will give you potential access to resources. It could give you potential access to insurance coverage for those resources. It will give you a billing code of autism that can then lead to third-party payers or insurance companies paying for therapies, paying for safety equipment, and such. That is different than an educational diagnosis. While they will look at the same criteria, a medical diagnosis does not necessarily ensure that a child will receive services within a school system. A school system will do their own evaluation separate from a medical diagnosis done either in a clinic or in a developmental psychology clinic or in a pediatrician's office. So recognize that this diagnostic criteria through the DSM is a medical diagnosis. In addition to those 2 areas, the social communication and the restricted and repetitive behaviors, if you have those 3 social communication areas and you have 2 of the restricted and repetitive behaviors, you've met the first part of the criteria, but you also have to have that these symptoms have been present since early development. So one of the things as we talk about assessment that will come up is the importance of a very thorough history. Are these differences, have they been present in that early development? We know that, again, that the autism is a neurological difference, and so that means that as the brain was forming, these differences were made. These differences were occurring in that development, and so you see these differences in early development. The other area is that these symptoms must actually impair an individual's functioning in their social, occupational, or other areas of life. So we see that there is a marked difference in how this individual is able to maybe complete those activities of daily living. Are they able to do some self-help things? Is it affecting them? Is it affecting their ability to communicate? Is it affecting their relationships? It has to have some sort of impact on that. And also, these symptoms cannot be better explained by an intellectual disability or global developmental delay alone. So, a caveat on the last one: autism spectrum disorder and global developmental delay and intellectual disability can co-occur. It's important to really find the differences. Is it only intellectual disability, or is there also autism? So that's where you want to look at that criteria. You want to look at those areas of social communication. You want to look at those areas of those restricted and repetitive behaviors. How are they impacting an individual? Do you see not just developmental delays, but do you also see those social communication and those RRBs present? If so, it is possible for an individual to have a diagnosis of ASD and global developmental delay. Really quick, the little difference between global developmental delay and intellectual disability. Global developmental delay is a generic term that we use for children typically under 5 that lets you know that they have delays in 2 or more areas of development. So these areas include fine motor, gross motor, communication, social emotional development, cognitive development, and adaptive or self-help skills. So if a child has a delay, a significant delay, usually of about 25% or more in 2 of those areas, we can say under the age of 5 that they have global developmental delay. We see delays across multiple areas of development. After a child reaches about 5, 6, 7 years of age, we know that that brain growth that we had in those early years, some call it the critical period, starts to change a little bit, and that the cognitive skills especially become much more stable around the ages of 6, 7, 8 years old. And so at around that time, if a child is still experiencing those delays, especially in the area of cognitive skills, that is when a diagnosis of global developmental delay would change to a diagnosis of intellectual disability. And that one we would feel like means that that child, even with interventions, is probably not going to catch up with their peers, especially in the area of cognition. When an individual is given a diagnosis of autism, it comes along with levels of severity. Now, this is part of the latest diagnostic criteria. And each of those areas, social communication and the restricted and repetitive behaviors, gets a severity level. They become either 1, 2, or 3. Before I start explaining those, I want to just state autism is there in early development, and it is a lifelong diagnosis. Once somebody has been diagnosed with autism, and if it's an accurate diagnosis, that individual is autistic for their entire life. Everything that we know at this point, autism cannot be cured. Autism can be supported, and there are things that we can do to help with development, but that diagnosis is steady and will be with the individual their entire lives. The severity levels that go along with those areas are fluid and a bit more subjective. So an individual, when they are diagnosed, will get a severity level for social communication. They will get a diagnosis level for restricted and repetitive behaviors. They do not have to be the same level. You could have social communication 3 and a level 2 of restricted and repetitive behaviors. In addition, those numbers, while the diagnosis stays the same, those numbers can change over time. Sometimes they can go up in severity, sometimes they can go down in severity. For instance, if an individual really responds to interventions, it may be that they go from a level 3 to a level 2 to a level 1. It's quite possible. May also be that maybe there's going to be a stressful time in their life or a stressful situation. Maybe at home they're a level 1, but when they go to school or they go to work, there's a level 2 and they need more support. So these severity levels are really about that. They're really about how much support does an individual need in order to help them in a situation. So the most severe, the most significant support, I don't really mean to use the word severe, the most significant support is a level 3. So this is an individual who has severe deficits in verbal and nonverbal communication skills. They have a significant impact that has a significant impact on their social functioning. So they will need more support in order to be able to deal with or to be able to help with their functioning of their daily activities. Level 2 is where you need moderate support for the ability to do those daily activities. So there is less interference, and they have some more independence and some more ability to handle those situations without that support. And a level 1 might have some problems, like might need some mild support in handling the situations that come about. So how do you tell the difference of those? Well, it's subjective, and this is where, when we talk about assessment, it will be very important to have a very thorough assessment, to have a very good understanding of what is this individual's life, what are their needs, and how much is their family having to work to help them, how much is the individual struggling to be able to do the things that they want to do, and how much support are they requiring. So these levels are given somewhat subjectively, and there isn't necessarily a checklist of items. If you see these things, this is a level 3, this is a level 2, this is a level 1. It is really about trying to understand the picture for this individual and how much support are they requiring in those situations. Again, it can change. One of the things I think that's important is for us as providers, it helps us get a framework for maybe where we need to do our interventions. What type of interventions does an individual need? How can we help this individual be able to be as independent as possible, be able to communicate as independently as possible, be able to interact as independently as possible? What kind of supports do we need to give them? Not just maybe how we're dealing with the environment, or how we're helping them be able to maybe become more flexible. What kinds of interventions are we doing in order to help that? There are some other things. While we have that diagnostic criteria, there are some ways that these might come up, some behaviors that you might see associated with autism that may be hints on how the individual is presenting some of the diagnostic criteria. The individual may have a flat affect. Remember, there might be difficulty with nonverbal communication. So that idea of facial expression or reading other people's faces might be affected, and it may come across as flat affect or a monotone voice because they're not necessarily using those nonverbal cues in order to be able to communicate. You may also see that in a decreased eye gaze. We do know now from autistic individuals that things like eye contact can be almost painful. So this isn't necessarily even about eye contact. We're not necessarily worried about having an individual look at us, but are they giving us some sort of indication that we are a part of that interaction with them? So you may see a decrease in that. This becomes important in the idea of joint attention. So joint attention is when an individual looks at looks at an object, looks at another individual, and then looks back at the object. It's that 3-point gaze, right? So it doesn't necessarily have to be great eye contact, it just has to be an indication that I'm including you. I think that this activity, this object is very interesting, and I want you to be a part of it. That's joint attention. So sometimes the decrease in eye gaze is an indication that joint attention is a very difficult thing. And that is one of those areas of social communication that we tend to see as something that is really different or really difficult for autistic individuals. We might also see decreased gesture use, as I was talking about before. So we'll talk a little bit more about what are some of those gestures that we might see, but you'll see nobody uses just one modality of communication, right? And so we put gestures, we put these nonverbals with our words in order to communicate. We use facial expression, we use hand movements, we use pointing, we use gesturing, come here, all of this to communicate. And you may see a decrease in those in autistic individuals. In addition, they may not show items of interest. So if you think about development in young children, if they think something is really interesting, or maybe they want to show you a new toy, they bring it to you. But that may not happen. Again, we're looking for qualitative differences. Maybe they do it sometimes, maybe they don't. Other times they're more than happy to play it, just only look at that object by themselves. They never bring and show objects. Something else you may see is childhood apraxia of speech. We know that between 20 and 30% of autistic individuals will have difficulty with speech, and about that many may remain non-speaking through their entire life. One of the reasons that those that remain non-speaking, a lot of times, sometimes at the root of it is childhood apraxia of speech. So look for those characteristics of, is it really difficult to do imitation? Is it really difficult to, are they kind of groping at trying to get sound going? Does it look like they're really struggling? And they may be experiencing apraxia of speech. You may hear jargoning or you may hear echolalia. So jargoning is just those, those words, those sounds kind of together. There may or may not be true words in there. Typically, jargoning, though, will follow an intonation pattern that sounds like conversation. Sometimes jargoning will be echolalia. And there can be different kinds of echolalia. There can be immediate echolalia. They will repeat the last word that you said. Or they can have delayed echolalia, where they're maybe saying a line from their favorite TV show. We're going to talk a little bit later in the slides about the importance of something called Gestalt language processing and looking at that echolalia as meaningful communication. Another thing that you may see is difficulty with pretend or imaginative play. We'll talk more about that. Their play also may be really repetitive. They may follow those same schemas, those same themes in their play all the time, and they don't really break out into very flexible play, imaginative play. They may be repetitive. They may have a real interest in interesting items. It may be anything from, I've worked with kids who like to carry around clocks, or like to carry around the spatula, or the kids who like to play with medicine bottles. And while maybe all kids at some point want to do those things, these kids do it again at a rate and a quality that is very different, where it's really marked that, oh, he always has to have 2 items in his hands, and they have to be cylinders. And so that is really different than what you would see in neurotypical development. You may see sensory differences, as we talked about. They may be sensory seeking, or they may be avoidant, and this could be anything from oral sensitivity, or some kid who's always chewing on things, to auditory, to visual, to proprioceptive differences that they may be experiencing. You may also see hypotonia, so just difficulty in just weakness in their muscles, and this sometimes shows up as fine motor difficulties or clumsiness, or for us maybe difficulty with oral motor movement, so it may show up in feeding, or it may show up in speech development. And then this difficulties with ideation, we'll talk more about this. So some think that this is part of the restricted and repetitive means, like they have an idea how they want to do something, how something should be done, but they can't figure out how to get it going. They can get the idea, but they can't get that motor plan going necessarily for play or for communication. We'll talk some more about that in the later slides. So we're going to go a little bit deeper into each of these subjects. Let's talk about what are some of those early social skills that go along with social reciprocity. Because we know, again, if this begins early in development, we should be seeing some signs in early development that things are following a different path. So what kinds of things might we see in neurotypical development that we don't necessarily see, or that we see a difference in quality in autistic development? So that responsive social smile. So when you are working with a young infant, and the caregiver, the parent walks by and smiles, picks up the kid like this and smiles at them, and the kid smiles back. We may not necessarily see that in autism. So again, this is where those probing questions and that interview and case history become really important. Did the parent see this in those early months of development? Did they see that in shared enjoyment in those games? When you were playing the peekaboo games and when you were playing the little tickle games, were there smiles? Were there indications from the child that they wanted that game to go on? Does the child respond to their name? How many times do you have to call their name in order to get their attention? Do you actually have to hit them on the shoulder to get their attention, along with their name? A little tap on the shoulder. Does the child early on come and check in with the adult and make sure that the adult is there, whether that be with a look or actually moving towards the adult? Do they do that? Do they have interest in other children? Are they watching early on? Remember, one of those early play developments is observant play. Are they doing that when they're really young? If you're not seeing that, and you're not seeing these social smiles, or you're not seeing an interest, and you're having a hard time getting the attention, you should be considering these are differences in social reciprocity. These are differences in social communication. Also, that they have a difference in how they participate in back and forth games. They may enjoy games like peekaboo or the tickle games, but maybe do they ever initiate them? What do they do if the adult stops? How do they keep those games going? What is the continuation? If that looks different, if that doesn't happen, we need to be thinking these are differences in social communication. These are differences in social reciprocity. Then for children as they get older, so that's that early development, but as they're getting into those toddler and preschool years, and even a little bit older, what does social reciprocity look like? Well, as they get older, we expect in development that we are going to see increases in quantity and in quality. But with autism, we might not see those increases in either of those. So as children get older, are we seeing their play becoming more complex, more interactive? Are they drawing people into their play? Are they interested in playing with others? Do they want that interactive play? Do they co-create? Do they take turns? Do they sing songs together? Do they like being a part of that group? If the answer to those is no, we should be thinking these are social reciprocity differences. Think about that give and take in conversation. Remember, we talked about earlier about how you have that give and take in those games. There's a social smile. The adult does it, the child does it, then the adult does it again, and it goes back and forth. There's that vocal play. Well, now this is give and take in conversation. Can the child comment? Can they offer information? Are they asking questions? Are they interested in what the other person is thinking and experiences? Can you recognize that somebody else is involved in this? And on that, do they recognize that others' experiences matter? Do they get that other people will have potentially have a different point of view? Other children may have a different way of playing a game, or they may have different ideas. How well does that sit with a child? Are they flexible about that? Can they handle those differences in play? Can they handle a variation in the play that maybe they didn't expect? If the answer is no, then we're like, these are social communication differences. These could be restrictive and repetitive behaviors, and it should get us thinking about, is autism a potential diagnosis for this child? Remember that second area, we had to have nonverbal difficulties. There is a lovely graphic that's going around about the importance of having 16 gestures by 16 months. So at 16 months in neurotypical development, we have a kid who is just beginning to build their vocabulary, right? But that doesn't mean that they're not communicating. That doesn't mean that they aren't good communicators, because they're using other means to communicate. So they're using that social reciprocity, but they're also using gestures to communicate. They may be putting out their hand for a please give me, I want that. They're pointing, they're shaking their head, they're reaching for things, they're putting their arms up to be picked up, they're waving, they're starting to point, they're blowing kisses, they're doing a shh gesture, they are nodding their heads, giving thumbs up, they're doing a shoulder shrug for I don't know, they're trying to do high fives and fist bumps. These are all communication. If you have a child that is autistic, you may not see these gestures, or again, it may be that the gestures are not directed towards anybody. They may do the gestures, but maybe they're not showing, actually looking at somebody when they're doing them or turning towards somebody when they're doing them. Instead, what you may see is something like hand as tool. So instead of a give gesture or a point gesture for wanting something, they may take another person's hand and put it on the door to open when they want the door opened. Or they may put their hand on the object, or they may only bring a cup, but they don't necessarily point to the refrigerator or indicate that that's something that they want. If we put some of these signs and symptoms of ASD with developmental milestones, like when should you be seeing these? Always keeping in mind neurotypical development as kind of a guideline of expectation. Again, it's a window, it's a wide range of when these skills happen. But if we aren't seeing a child point to something that's interesting by 18 months, we should be starting to think we need to look at this further. If by 24 months a child isn't noticing other people's emotions, so they're not going up and offering a hug, or they're not going up and or responding to the tone when somebody says no versus don't do that, the differences in tone, if they're not recognizing those by about 2 years of age, we should be asking some more questions. If they don't take notice of other children or want to join in that interactive play by around 3 years, that's an indication that that is a difference in their development. And in your studies, you should have learned that there's a difference when we're talking about disorder versus a delay. A delay is just this kid looks like a younger kid. A difference is the disorder is the difference when that path of development is taking something that doesn't look like what we would necessarily expect for neurotypical development. So when we see these differences, when we see that they're not interested in play, that they aren't really doing pretend play by around 4, and they're not really noticing others, these are differences. These aren't just looking like a younger kid. These are significant changes to that trajectory of development and require us to look further into why that might be happening. Keeping in mind how we are working on differentiating whether or not this is autism or whether this is a speech and language delay, let's talk a little bit about some of the differences that you might see in communication on a speech delay only or more consistent with autism. So if it were only a speech delay, remember it's going to look like a younger kid, so your vocalizations are going to be directed for a communicative purpose. You're going to see a variety of communicative functions. So you may see requesting, you're going to see commenting, you're going to maybe see protesting or refusing, and it's going to be very functional, and it's going to be directed at an individual. They are trying to communicate. Even if they're having difficulty doing that, there may be gesturing, there may be sounds, but it's directed towards somebody for a specific purpose. And those communication attempts are spontaneous. They're not just imitations. They're not just filling kind of a schema. They are spontaneous and oftentimes somewhat novel. There will be a range of those strategies that we'll use. So they may try eye contact. If that doesn't work, they may try grunting. And that doesn't work, they may try gestures. They may try facial expressions, different ways, different means of communication versus the same thing over and over and over again. And they will respond to the social overtures of others. So they will be able to maybe follow some commands. They may be able to read those facial cues. Putting a gesture with words may actually really help them be able to understand a communication. And they have evidence of that joint attention, that 3-point gaze that I talked about. So it's really, again, it's about that relationship. Are they in this with another person? Are they using communication functionally and in appropriate means? That's more often associated with a speech delay. More often associated with autism is this use of jargon or sometimes repetitive speech. Some people call them scripts, some call it echolalia. We're going to talk about Gestalt language processing in a little bit, but you may see this repetitive speech that is used over and over again. It doesn't mean it's not functional, that doesn't mean it's not meaningful for them, but they may use it in a variety of contexts that may not be easily understood by an unfamiliar listener. Sometimes they will have undirected vocalizations or words. They may be talking. It may even sound like really meaningful communication, but maybe they're not looking at an individual. They are using gestures, but they're not using those gestures towards anybody. So they may be trying to get out of the door, and they may be pointing at the door, but they haven't looked back to let somebody know, like, hey, I want out of the door. I want out of this room. But they'll also be using the same strategies over and over again and don't have a lot of variety in how they're able to communicate those. They may have a lot of words. They may actually be able to say a lot of words, but they may have a limited functional use for those words. So maybe all the words they use are just there for labeling. And they can say all kinds of things. They can say the alphabet. They can count to 100 when they're really young. They can tell you all the colors. They can tell you all the shapes, but they cannot ask for juice. So it doesn't have a functional purpose necessarily, but they could have a large vocabulary. And lastly, their communication attempts are a lot of times prompted, or they are modeled, so they become imitation for them. Those are some ways to look at the difference. And if you'll notice, really, there's some similar things in those two lists, but again, it comes down to the idea of quality. Quality, yes, this may have a lot, they may have words, they may be doing some of these nonverbal strategies, but they're limited. They are not necessarily for functional purposes. So again, it's looking for quality. Yes, maybe they are requesting, maybe they are even giving you some eye gaze, but they aren't doing that spontaneously very often. It's requiring a lot of work from you versus a child with a delay is doing that more independently. So one of the areas where we see this, of course, in young kids, because what young kids do is play. And so we will notice that the play in neurotypical development and autistic development is different. So first, this slide is about what does the typical trajectory of play look like when we're thinking about children. So early on, play involves the use of kind of real objects to pretend scenarios. So this pretend play might look like, oh, I've got a play kitchen, I'm going to make you some food, but I'm using a bowl and a spoon, and then I'm going to feed it to my baby, and I'm going to put a blanket on my baby. And one of the ways that kids learn this is through imitation. And so some of their early pretend play is actually scenarios that they see in their life. So they might do cooking or household chores or things they see their caregivers doing first. But then it becomes more symbolic. So they start to use objects for something other than their purpose. So they may, instead of using the play food, they may have blocks for that food, or they may use a stick as a spoon, or a block as an airplane to fly. Or then it may get to the point where they're not even using any objects and they're just kind of flying a pretend object through the sky. Then that imaginative play becomes more and more complex. And they maybe start to dress up and they start to use voices and emotion and characters, and they're using stuffed animals and dolls as objects within their play that they are acting upon, and they start to do a variety of themes in this play, and they're accepting ideas of other kids. It becomes cooperative, and they're themes of play become more complex and varied. Take that and compare it to the play that we often see in autistic kids. Pretend play may be late, it may look atypical, and it may be really limited in its range of themes. They may play doctor, but they're going to, every patient's going to have the same sickness and the same remedy. And if you try to introduce a different remedy, that's upsetting. No, this is how we're going to take care of this. Everybody gets a Band-Aid. There may be limited imitation of pretend play, and they may prefer to do these play routines on their own. Their play may be more cause-effect. It may be more sensory exploration. And they may have difficulty acquiring symbolic play. So they sometimes will have real concrete or literal thinking. A block is a block. One of the stories I like to tell is about a young girl that I worked with, and we were playing babies, and I gave her the bottle to feed the baby, and she said, I can't feed the baby this, there's nothing in the bottle. And so her thinking in that play was very literal. The bottle was empty, so there was no way to feed that baby. She did not yet have that skill to be able to put that imaginative part into her play. Let's talk a little bit about praxis now. And this is not the test. This is that idea of movement, of being able to think of an idea and then carry it out and then be able to make adjustments in order to do it better and differently. So this is something that you will see with that is at times difficult in autism. We as speech language pathologists will see it in play. You may see it in oral motor movements. So it may come up in feeding, it may come up in speech, and it may come up in other areas that I'll show you. This is also kind of nice information to know, because when we're thinking about autism, we really do need to be thinking about the whole child and all of those areas of development. So what is praxis? Well, first you have ideation. You have an idea of what you want to do, whether that be a movement idea or a play idea or a speech idea, and then you execute it, or at least try to, and then you have to give yourself feedback, like how did that go? What was the outcome? Did I go up those stairs okay? Did I play and push that car around like I wanted it to? Did I say the right sound? And then you need to problem solve and say, well, that didn't go quite like I wanted to. That wasn't the word I wanted to say. So what do I need to do differently? Do I need to put my tongue in a different place? Do I need to actually voice? Of course, you're not necessarily going through all of these processes of thinking, but this is what's happening in praxis. You're not doing these necessarily consciously. And then you need to change your motor planning. So how do I organize and carry out a different action? How do I change that and make what I want to happen, happen? So this is a thing that, as in typical development, gets better and better and better with play, gets better and better and better with each repetition. But in autism, what we may see instead is frustration, because this is not working. Something's not working, but maybe they don't know how to fix it. And so they begin to withdraw from activities. So I know that I can play over here, and I know how to stack these blocks, and I can knock them down, and I can stack them again, and I can knock them down, and I can do that over and over again, and I don't have that frustration. It may also sometimes appear, if they have difficulty in praxis, as anxiety, because they know maybe something is going to be hard, and so they won't try. We may see it also, this difficulty in praxis is getting stuck in that routine. Like I was talking about the blocks. I don't know another way to play with these blocks, so I'm just going to keep doing it over and over, the same thing over and over again. So it gives them a strong need to control that environment, because they don't necessarily know how to problem solve and motor plan and make what they want to happen. So they keep things really rigid. They keep things they keep it in control, because they then don't have to have that anxiety. We may also see this as a poor ability to organize, and then that means a difficulty in learning new motor skills. You may also see these kids as sometimes having some difficulty with clumsiness. So when we're talking about autism, we really work with a team most of the time. So it's important for speech language pathologists to kind of know about these things. They may show up and they may be dealt with more by the occupational therapist, But we're going to see these coming into our therapy room in oral motor skills and in play skills, and we need to be able to know how to help them. And for us, it will probably show up as a motor speech difficulty. A lot of times some kids will come with a diagnosis of child apraxia of speech, or we may give that. So how do we see these difficulties in praxis expressed in our field? Well, we may see a child who has difficulty with motor speech. So they may have limited babbling or variations or limited variations within that babbling. Quite frequently when I'm gathering histories, I hear he didn't babble, or he only went da 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 da. He didn't do variegated babbling. They may have a limited phonetic diversity. There's only a few sounds that they're going to say. They make all kinds of different errors. Those errors become more as the difficulty of the word or the length of the utterance increases. They may make omissions. They may make vowel errors. They may have difficulties with those suprasegmentals, with stress and intonation that may sound different. They may have a sing-songy voice. They may go over those same stress patterns over and over again and use them. They may lose previously produced words, things that they were saying and now they're not saying them. They may have more difficulty with voluntary things if you ask them to say something versus them just saying it. You know, sometimes you'll hear parents say, one day out of the blue he said that and we haven't heard it again. So you may hear those kinds of things, and those can be difficulties with praxis. So other signs that you might see that can let you know that there's difficulty with praxis as far as oral motor movements. You might see difficulty with smiling and blowing a kiss, puckering. These may show up in motor skills, but they may also show up in feeding. And so it may mean that they have choking or they are pocketing food. There's just this general awkwardness and clumsiness that you may see for these children. One of the topics that you will hear about as you're working with autistic individuals is how did this individual learn language? How are they understanding language? How are they using language? I want to contrast that first with what we think of with neurotypical language development, or what is also called analytic language development. So this is what most people think of as far as language development. A child meets certain benchmarks at certain ages. We see their language skills grow in quality and complexity from smaller units into larger units. They get their first 50 words, and then they're able to take those words and put them into 2-word phrases, into 3-word phrases, and they continue to grow like that. Sometimes you will see this in autistic children's language development, but sometimes you will see something different. Because of the understanding of patterns and concepts as wholes, sometimes we will see language development in children with autism develop in those patterns, in those large units rather than the smaller units that we see in analytic language development. So sometimes you will see Gestalt language processing or Gestalt language development in autistic children. Now, a note aside here is that not all children with autism are going to learn using Gestalt language development, and not all Gestalt language developers it's not only going to be seen in autism, it can be seen in other development. But the way to think about Gestalt language development is we used to have this framework where we looked at echolalia as something that was to be extinguished. This is old school thinking. We no longer think like that. Now we have this understanding that autistic children may be learning learning language in chunks. They may be learning who stole the cookie from that song, who stole the cookie from the cookie jar first, and that may mean for them, I want a cookie. And so they will use that pattern, they will use that Gestalt in order to communicate. Some things to keep in mind about Gestalt language development is that this is functional communication. It may take some detective work to figure out what it is the child is saying, because sometimes it might be hard to know where a Gestalt came from, but maybe you can figure it out. Sometimes these Gestalts can just be almost an intonation pattern, but you see this repetition of this whole chunk of expression to mean something. You may see it in repeated or similar contexts. So our job then as therapists is to help these kids take those chunks that they've learned, be able to mitigate or mix those chunks into new chunks. So if you have a kid who can say, who stole the cookie, and want to go outside, you can help them get now, want the cookie. And then eventually, as you work through the levels of therapy for Gestalt language processors, you get down to that single word. And the reason that this is important is then you begin to build again those single words into novel and spontaneous phrases that the child can use for communication. So now that we have an understanding of what autism is, very quickly, how do we assess it? What are some of the observations? How do we go about looking for those behaviors in our observations? Well, assessment for autism is done behaviorally. We don't have a medical test for it. We don't have just one gene that we're looking for. We know that in the genetic information that we've gotten that it's a variety of genes, and we can see differences in how those are presented, and we're still learning more and more about that. So we look at observable behaviors to describe these characteristics. We've gotten much better at asking pediatricians to be looking for these. So parents sometimes will do the MCHAT in their pediatrician visits. They may do the ages and stages questionnaire or the first year inventory. And these screeners ask questions about some of those behaviors that we've talked about, those early behaviors, and they give an indication of whether or not the child may be at risk for autism and whether or not they need further evaluation. So if they do need further evaluation, you would go to typically an interdisciplinary team, hopefully for the best evaluation. You want to be looking at this have a variety of people looking and spending time with a child, doing an in-depth family history that looks not just at family history, family health history, the social aspects of the family, as well as pregnancy information, delivery information, the child's health information, how they're doing with those areas that we talked about with social communication and restricted and repetitive behaviors. Is this child having difficulty with transitions? Is this child, how are they handling things at home? And these and then you want to and those kinds of questions are a part of this of some of these diagnostic tests, especially the CARS and the GARS, the Childhood Autism Rating Scale and the Gilliam Autism Rating Scale. Those are checklists for behaviors. They're typically done in tandem with an interview with parents by a team, and then you do some observable, you do some observations of the child. However, the gold standard for diagnosing in autism is the ADOS, the Autism Diagnostic Observation Schedule. And this is a series of activities, free play activities that you do with a child. And this is you have to be trained in the ADOS, and this is typically done by a psychologist. And you are setting up scenarios that will pull out those behaviors that we talked about. So you may be blowing bubbles and then you stop and you see, how does this child ask for more? If you pull out a bunch of toys, do they want to interact with you, or are they perfectly happy to play on their own? Do they come to you for help? Do they use gestures? You're looking at all of these during an ADOS. So that is the gold standard that you would want to use in addition to developmental testing, because we want to see, again, is this being explained by something different? What is their speech and language development look like? So you would typically give some sort of speech and language test, some sort of developmental test, along with this ADOS and a thorough history. So how do we intervene with autism? What do we do? Well, if we think about those areas of challenge, if we think about those areas of difference in social communication and restricted and repetitive behaviors, we tend to think that our interventions that we could potentially utilize would be behavioral, therapeutic, training of the caregiver. There may be medical interventions and referrals to any of those that we may need to do after we've done our evaluation. So if we're thinking about the areas that are impacted, what other areas would be included in an interdisciplinary approach to diagnosis and intervention? We need to think about, again, the child as a whole, that they are dealing with these social communication differences, potentially sensory differences that may cause some mental health differences and academic difficulties, as well as some medical difficulties, because we do know that about 25 to 30% again of autism, we do recognize that there are some genetic differences and some syndromes that autism is a part of. And so and in addition, we know that about a third of kids with autism may be at higher risk for things like seizures. So we do know that we want to have an entire team that is looking at this kid and helping this kid with whatever areas that they need support in. And while we're doing that, we want to make sure that those areas that we're looking at come from a neurodiverse affirming practice. We want to look at the strengths of this child and what is the whole picture. By doing that, we can look at that whole picture. What are the areas that are being affected? What are the areas that the family or that individual are letting you know that they need help with? And these are all neurodiverse affirming practices that we want to make sure that we are a part of. So let's go through and talk about these. As I talk about neuroaffirming practices, there's the first one on behavior interventions is sometimes a bit controversial, but it is changing. So one of the first behavioral interventions and one of the interventions that is frequently recommended after a diagnosis of autism is ABA, or Applied Behavioral Analysis. It does have a controversial past, but ABA is changing to be more neurodiverse affirming, to be more child-led, to be more relational. And if you can find a good program, but it is based in the field of psychology, and it teaches behaviors through an ABC method. Teaches behaviors that there's an antecedent. There is something that happened, something that brought about a behavior, and that behavior can be positive or it can be challenging, and then there was a reaction to that behavior, a consequence. And so getting back to psychology and thinking about Skinner and how we learn through conditioning and how we learn through reinforcement and punishment, ABA will typically use those kinds of ideas and understandings to help bring about behaviors that will help the individual, again, be able to function and do those activities of their daily life most independently. From the field of psychology, another one that comes from the field of psychology is called the Early Start Denver model. And the Early Start Denver model can be done by a variety of practitioners, including speech language pathologists. You can get certified in it, and it uses some of those ABA techniques, but in a naturalistic, child-led play environment to help bring about an increase in social communication and play activities, as well as the other areas of development. It is one of the models that has a significant amount of literature behind it that states that it has efficacy and that it is long-lasting for its results. Some of the other behavioral interventions you may see, you want to think about the impact of this on a family and how caregivers and children might be interacting. So one intervention in the mental health field that you might hear about is PCIT, which is parent-child interaction therapy, helping the parent and the child really work on that relationship and how they respond to one another through techniques. You may have parents who are learning about ABC, learning about the antecedent behavior consequence, or maybe programs that do that can help with that relationship with the child and the parent being able to interact in a more positive means. Therapeutic interventions are probably the ones that are most familiar to you, because autism is a diagnosis that we see typically in early childhood. We tend to hope to get these children and some early intervention. So early intervention takes place from birth to 36 months. Each state has an early intervention program, and in an early intervention program, a child is, if they qualify, they are given an individual family service plan that looks at how is the child's caregivers going to help a child meet their developmental goals. So this can be done by a developmental specialist, an occupational therapist, physical therapist, speech language pathologist. They go to the home, they work on these goals, they train caregivers on how to best interact and what developmental goals they may be working for. In addition, you may have some of the early therapies that are most typically recommended for children with autism are occupational therapy, and occupational therapy may work on fine motor and some of that praxis that we talked about, as well as emotional regulation and executive functioning that may be difficult for these kids. And then the speech language pathologist, the speech therapy will work on language and play, social communication. And one area that we haven't really talked about yet, but because so many of these children will have delays in speech and language, and the frustration that goes along with not being able to communicate verbally, your speech therapist may work on augmentative and alternative communication, or AAC. So finding other means to help this child communicate, whether it be low tech with pictures, mid tech, or a high tech device, and to help the child communicate. In addition, you may see other therapies that families will find very beneficial, including music therapy, social groups for kids so that they can learn how to interact with peers. There may be academic support, so using the use of visuals in the classroom is kind of a low support, all the way up to getting some special education. These kids may also need physical therapy depending on if they have any comorbidities or if they are having difficulty in gross motor skills. Some of the caregiver interventions, because you will find as you're working with these families that these families tend to be working pretty hard to help their child. And if your child has difficulty with social communication, has difficulty with social reciprocity, their play looks like not what you would expect it to look like, it can be really difficult for some parents to figure out how to best interact with their kid, how to best support their kid, how to meet their kid where their child is, and to play with them in a way that makes sense to their kids, to communicate with them in a way that makes sense to their child. So there are some programs that have highly that have caregiver training highly embedded within them, and some of the top 3 that you will see for the area of autism are the Hannon program, the More Than Words program. This one is specific to autism within the Hannon family, and it is caregiver training and helping the caregiver know like how to read those communicative clues when their child is giving them, because they may be subtle, how to play with your kid, how to take the kid who only wants to line up toys and turn that into a play routine. The same thing with the DIR floor time model. The DIR stands for developmental, individual, and relational. So it works very hard on training a caregiver on how to meet their child where they are, think about them as an individual, not comparing them, and then work on that relationship and building those circles of communication back and forth wherever the child is, working on those skills. And then the Early Start Denver model is also very highly regards caregiver training and pulling in caregivers into therapy, helping them obtain the tools that they need in order to most beneficially interact with their child. Some other areas that we know that can be of difficulty with autism, they kind of go hand in hand. As you work with families that their child is autistic, you will see that they typically have sleep difficulties. We know that children with autism will have differences in how they make melatonin. So sometimes these kids don't sleep very well. They have difficulty going to sleep. They have difficulty staying asleep. There may be toileting issues when it comes time for toilet training, in part because of those sensory differences. They may experience those senses of having to use the bathroom differently, and so that can be a really difficult journey. A lot of times kids with autism will have comorbidities. They may have ADHD, they may have seizures, there may be genetic syndromes involved, they may have other mental health issues. And so medical interventions, whether they be pharmaceutical or referrals on to other specialties, or working with mental health, working with individuals who specialize in how to work with sleep difficulties, toileting issues. One other that I didn't put on here that I should mention too is a lot of times feeding difficulties. So these kids, because of the rigidity or because of the sensory part, may have a real limited diet. They may be incredibly picky eaters. Medical interventions may be looking at what nutritionally are they getting. Do we need to supplement? As we go through those therapies for helping a child either learn how to use those oral motor movements to eat, or being willing to accept a variety of foods, textures, those kinds of things. I want to thank you very much for being here tonight. Remember that I will be office hours for this program on October 15th at 7 p.m. Eastern Standard Time. We can review this material, and we can sample and we will go over sample questions to help you prepare for the exam and help you get a framework of how to think about autism. I hope that this presentation has been helpful for you. You can also contact me if you would like to try to set up, or contact TherapyED or myself if you'd like to set up any tutoring one-on-one if you have specific questions that you would like. Thank you again for your time. I wish you the best on the praxis and the rest of your graduate career, and then your chosen career of speech language pathology.